Thank you everyone for joining us. Just hang on a few minutes and we'll be starting in the webinar in about 4 minutes. Thank you. Thank you everyone for joining the webinar. We will start in about 2 minutes. Hello, and thank you for joining us today. And thank you for bearing with us as we were troubleshooting a few technical issues. We have a few housekeeping items before we start today's program. I'm Andrea Jensen. I'm the education specialist for Allergy and Asthma Network. A few housekeeping items. All participants will be on mute for the webinar. We will be recording today's webinar. It will be posted on our website within a few days. So you can listen to it again, or you can share it with one of your colleagues. You can go to our website at allergyasthmanetwork.org, scroll all the way down to the bottom of the page and find our recorded webinars and upcoming webinars. This webinar will be 1 hour, and that will include time for questions. We're still having a few technical difficulties, so if you wanted to ask questions, you can send them via email to Chris Brown. That's K Brown at allergyasthmanetwork.org. We'll see if that will be a little bit of a workaround for us. We'll get to as many questions as we can to conclude today's webinar. We do not offer CEUs for this particular webinar. However, we do offer a certificate of attendance. You may have noticed that we are using a different platform this year, hence a few of the technical difficulties as we switch platforms. Instead of being able to download the certificate during the webinar, you will receive an email after the webinar with resources about RSV and also a link to be able to download your certificate. So let's get started with today's webinar. Winter can be a challenging time when we are spending most of our days indoors, along with several viruses in the rooms with us. This makes it easy to spread the viruses to others. The last few years have been focused on COVID, but the flu and RSV are still circulating. This has been a bad season for RSV, and it has affected all ages. Did you know that RSV can affect babies, older children, and even adults? Today, we'll learn more about RSV, who it affects, and what we can do to prevent it. Dr. Tejwani, do you want to go ahead and forward the next slide? Wonderful. So before we continue, and I'll read his introduction, Allergy and Asthma Network is a grassroots organization that was started over 35 years ago by a mom who knew that other mothers like her needed resources and support. Our mission is to end the needless death and suffering due to allergies, asthma, and related conditions through outreach, education, advocacy, and research. Today, it's my pleasure to introduce our speaker, Dr. Vick Tejwani. Dr. Tejwani is an assistant professor at the Cleveland Clinic, Lerner College of Medicine. He joined Cleveland Clinic, Lerner College of Medicine as a physician and investigator in the asthma and COPD centers after completion of a pulmonary and critical care fellowship at Johns Hopkins University. Dr. Tejwani is an active scientific investigator in asthma and COPD and also attends in the medical intensive care unit, including care of critically ill COVID-19 patients since March of 2020. He is passionate about patient education and translating nuanced evidence and data into actionable recommendations. He has enjoyed partnering with Allergy and Asthma Network on numerous patient-centered and academic endeavors. Thank you for being with us here today, Dr. Tejwani. We look forward to you sharing your unique perspective to treating those with respiratory infections.
Perfect. Thank you so much, Andrea, for the kind introduction, and to you and Allergy and Asthma Network for organizing this. I think is certainly a timely topic on the top of everyone's mind, and if not, impacting everyone in some way or another. So I'm really honored to be here, spending the time talking to you all about it. By way of disclosures, I have no relevant disclosures in terms of conflict of interest. I do have one disclosure that will just impact some of the experiential knowledge I'm able to share, which is that my time in pulmonary clinic and in the intensive care units is spent caring for adults, so those over 18. And as Andrea mentioned in the background, RSV affects adults, but also has a significant pediatric burden as well. I've certainly reviewed the literature, discussed it with a number of my colleagues as well, but just in terms of my own practical experience, I'll be able to offer a little less on the pediatric side. I think as Andrea mentioned, the webinar will be recorded and posted for those that may not be able to attend today or want to listen back to hear anything that was missed. And I believe Andrea went over this as well, but just to reiterate the mission of the Allergy and Asthma Network, which is certainly something I'm proud to be partnering with and furthering. So our main objectives today really are to go over what the respiratory syncytial virus is, who it affects, which is quite a wide array, the signs and symptoms, how it's treated, the mode of transmission, and by reviewing the mode of transmission, I think we could go over the best methods to prevent it. Throughout this, I'll try to contrast it a little bit, or in some ways compare it in similarity to COVID-19, which I think we've all, whether by our own volition or not, received a little bit of a crash course on over the last 2 to 3 years. So, Andrea, I'm not sure if we're doing this, so I think if we're doing this, I'll move past this just to go over introducing what is the respiratory syncytial virus. So RSV is a virus. It's essentially a seasonal virus. It's one of the common viruses that occurs every year in the winter. And this year, through a number of combinations that I'll talk about, we're having what's been referred to in the lay media, and I think now among the scientific community as well, as a triple-demic, which is essentially a confluence of 3 respiratory viral illnesses occurring at one time. And this was quite profound starting in the October-November months. And this is a combination of RSV, influenza, and COVID. And I think the reason this has occurred this year, because of course COVID has been with us for 2 to 3 years, is this is probably since COVID started in March 2020, the first winter where really there are very limited precautions beyond the usual. And I think there's a number of features contributing to that as well. So we're continuing to see COVID numbers, although less than usual years, but it turns out a lot of those precautions that we were undertaking as a society for COVID ended up preventing RSV and influenza as well. And in particular, the pediatric population this season is experiencing a higher burden of RSV. And there's some other background related to pediatric hospitalizations and some other kind of things that have occurred societally in terms of worker supply and even supply chains that I think have aggravated all of these things. So none of this is really occurring in a vacuum. It's all occurring in this backdrop of everything that's been evolving over the last 2 to 3 years, culminating in really this very high burden of these 3 viruses at one time. And this is, again, received certainly appropriate attention in the news and in the medical literature. There's quite a bit that our hospitals are being overwhelmed by this. And briefly on the pediatric side, there are really 2 main contributors to this. One is the higher caseload, and the higher caseload is likely because most children, as we'll talk about later, typically would have experienced this before 1 year of age. But children that have been that young or been 1 or 2 have not actually gotten that exposure. So it's kind of like everyone, from 1, 2, and 3 is getting it all at once as social distancing measures are laxing. The other thing that occurred is, unlike COVID, which is predominantly a disease, although it can affect children, it's predominantly a disease of older individuals, there was a lot of efforts at expanding out adult care units, adult intensive care units, adult medical intensive care units, and particularly early in March and 2020 and onward, there was much less volume in terms of pediatric illnesses because of those social isolation measures or social distancing measures that were taking place. And that led to a little bit of a reallocation of the workforce and hospital units in the United States. So a combination of a higher quote unquote demand, if you will, because of a higher infectious burden, and then also a lower supply of the ability to care for those individuals has kind of led to this unfortunate perfect storm of the hospitals being overwhelmed. So again, I think it's good to helpful to anchor this to COVID just because it's something we've all become familiar with. So RSV is short for respiratory syncytial virus. In terms of the usual symptoms in most people, it essentially feels like the common cold, like a rhinovirus or an influenza. Fortunately, and this is fairly similar to COVID, most symptoms in most people are mild, and generally people will recover a week or 2. Unlike COVID, we're fortunately not seeing as much of the long haul type of symptoms or long COVID type of symptoms that are observed with that virus, as that tends not to really be a feature of RSV. It's you kind of get it, you feel terrible, and hopefully don't get too sick, but you do recover overwhelmingly without any residual symptoms. Again, unlike COVID, RSV can actually be serious for children, and then similar to COVID, it can be serious for individuals that are older and that have some type of immune compromised status. In infants, it can cause bronchiolitis. So the airways, they essentially go down, they branch out into bronchi. And then the very small part of the airway where gas exchange or oxygen actually comes into our body and carbon dioxide leaves is called a bronchiole, and that can get inflamed. And then it can also just cause a full-blown pneumonia in infants. And in adults, in those that are immunocompromised, it can lead to pneumonia, or those that are older, it can lead to pneumonia. But the other thing it can do, which we see a lot of on the adult side of care, is that for individuals with pre-existing chronic heart or lung conditions, typically congestive heart failure, COPD, or asthma, it can actually cause those underlying diseases to flare up and then severe enough to actually necessitate a hospitalization. So we've touched upon this a little bit, but in terms of who it affects, it's predominantly the extremes of age group, along with those that are immunocompromised. This is data that is compiled on the CDC website, but from a number of resources that are listed at the bottom. So in terms of per year, we're looking at 2 million outpatient visits per year. approximately 60,000, and this is referring to children, so starting from the left to right. In children less than 5, we're looking at 60 to 80,000 children that are hospitalized per year. And then in adults, just given much more individuals in this age group, we're looking at 60 to 120,000 individuals that are hospitalized. Fortunately, despite still causing some mortality, though, the death rates are fairly low. So at 100 to 300 deaths of children under 5 and 6,000 to 1,000 adults over 65 per year. The one thing I do want to emphasize from this, though, and you'll notice the years of the citations at the bottom, is all of this data is from prior to this current kind of epidemic of the virus that we're experiencing. So this is really historical data, and we have some of the data of this in real time, but we really won't know until later what the total effect is from this winter season to be able to compare it to historical benchmarks. But it certainly seems that we're on track to be higher than anything in recent history. So typical to the seasonal flu or any respiratory viruses, there is a seasonal onset to this. It's usually mid-September to mid-November. It was a little bit earlier than usual this year. And the peak as well was a little bit earlier. We seem to be coming down from some of the peaks in November and December. This is, again, what's shown here, a typical year. And a part of this just has to do, and we'll talk about ventilation later, is that people are just inside more during these years, and the transmission of these things is much higher, or during this part of the year, excuse me. So it's certainly a very widespread virus, and just given the weather variations, it also varies by region. So we're starting to plateau and actually now come down here in the winter regions in the Midwest and the Mid-Atlantic. In terms of those most likely to be hospitalized, it's younger children. And as we kind of talked about, and we'll show some data for this, that they're much more ED visits and hospitalizations overall. And then when we're talking about older children, we're really referring to the 2 to 4 age range, where we're seeing the much higher rates compared to years prior. And so this is just to give a sense of hospitalization rates of RSV. So you'll see in this kind of green line going up that peaks out at 5. That's from this year. So that's 2022 to 2023. And you could see it's much higher than anything in years prior in terms of the peak. What we're looking at is the hospitalization rate per 100,000 people. So I think certainly on track to have a much higher burden than we have in years past. And interestingly, and I suppose not surprisingly, you'll see that the 2021 numbers and 2022 numbers are actually fairly low. And that's in part given the social distancing measures that were undertaken for COVID. You can see then the gray line, which indicates 2018 to 2019. So this was, of course, before kind of better days where none of us knew what COVID-19 was, that the rates of this year are still higher than that. So it's not all just a backlog of COVID. I mean, there's certainly seemingly something else going on beyond that might be underpinning this. And then this is what I was referencing earlier. So this is a patient ER visit by age group. And unequivocally, those that are 0 to 1 years of age still remain at the highest risk and have the highest emergency department visits over this period, much higher than years past again. But where you're really seeing the difference is in this blue dotted line, which is the 2 to 4 years age group. And again, these are kids that in years past, I essentially think of these as we're basically getting 2 to 3 years of RSV exposure and RSV contraction in one season. It's kind of that backlog of kids that would have been spread out every winter that are now all getting it at once. In terms of the signs and symptoms of RSV, so fortunately in most people, they're just kind of your typical sick symptoms. So runny nose, decreased appetite, feeling terrible, a fever, sneezing, coughing, and then individuals can get wheezing, and particularly in those with pre-existing asthma. And RSV in individuals, for example, that maybe have not had asthma ever in their life, but have a family history or some type of predisposition, not only can flare, it can actually cause that disease to manifest. So if you have individuals with pre-existing asthma, it can certainly flare it up. But the other thing it can do is actually essentially precipitate disease onset for those that have some type of genetic or otherwise environmental predisposition to the disease. So it affects babies. It usually they'll feel pretty sluggish, lethargic, kind of the general signs and symptoms that you expect to see in a sick infant. And I'll just contrast this from COVID again, which remarkably causes very mild and little disease in children. This actually can cause a very severe lung infection or pneumonia or bronchiolitis, and is in fact the leading cause of this pneumonia in infants, in children under 1, and the leading cause of hospitalization. So some of this again is related to prior seasons. A lot of the epidemiologic data we're talking about doesn't really account for we're in the midst of right now. But prior to this, most infants were infected in their first year of life. And essentially everyone would have had it by age 2. Although there are children with pre-existing risk factors like immunocompromised status or heart and lung are more likely to be hospitalized in aggregate, just because there's so many more children that are healthy. Those that ultimately are in the hospital still are more likely to be healthy. But the 3 or 4 big risk factors are prematurity, heart disease, lung disease, and immunocompromised status. And then ultimately 2 to 3% of sick infants will need to be hospitalized. And again, historically, we're talking about kind of one age group getting this per season, but this year we're seeing this thing where 2 to 3 phases of age groups are getting it all at once. And this is just to reiterate some of the historical data. We're certainly on track to be higher than this, but even before this kind of epidemic, we're seeing that there was this number that we presented earlier, about 2 million outpatient visits per year, 60 to 80,000 hospitalizations per year. And although a small number, still a very unfortunate number of 100 to 300 deaths per year of young children that have kind of yet to really embark on their lives, unfortunately. And this is the risk factors for more severe disease are prematurity, and there are some cutoffs to actually give preventative medication, which we'll talk about. Being very young, less than 6 months, chronic lung or congenital heart diseases, immunocompromised, and neuromuscular disorders, because they just don't have the ability to kind of expectorate and get out some of the secretions that start to occur with an infection, such as a bronchiolitis. And I draw your attention to this because I think those that have cared for children or have children certainly are familiar with these symptoms, but I just draw your attention to this given that these are individuals that certainly cannot communicate themselves regarding how they're feeling. So beyond your usual 6 symptoms, if an infant is irritable, if there's decreased activity, decreased appetite, not as many wet diapers as you would anticipate, these are all signs. Well, the wet diaper is more a sign of dehydration, but signs that something else might be going on. And then apnea, or if they stop breathing, that's certainly a emergent condition with an immediate 911 call. And as we've touched upon, once they're getting to that stage, that risk of progressing to more severe disease is a little bit higher. So probably seeking at least urgent care at that point, either same day or the next day, would be important. And so when we talk about preventing disease, I think it's important to understand the distinction of transmission. So if you all kind of think back to March or April of 2020, there was a lot regarding not touching your face, or there are many news anchors talking about not rubbing their eyes. I'll speak for myself. Anytime we received any type of package, we were kind of wiping it down vigorously, not really understanding, how COVID was transmitted. But it's since become apparent that COVID is transmitted more by respiratory droplets. So this is somebody coughs or sneezes or breathes even, and the droplets of the virus kind of linger in the air for a period of time. RSV and the flu are generally transmitted a little bit more through contact transmission. So what that means, this is kind of the things we used to think about before COVID. So I sneeze on my hand, I don't wipe my hand, I open a doorknob. Now RSV lives on that doorknob. you then use the same doorknob, you rub your eye, you've got the RSV. So it's good and bad. I mean, it's not necessarily better or worse. It's just a different method of transmission and requires different methods of precaution. So typically what you're going to use for that is much more hand sanitizing. Certainly if you go out and you touch a doorknob or something in public, this would be one where you don't want to touch your face until you wash your hands, or sanitize. Fortunately, most hand sanitizers will kill this virus. And then in terms of the mask for RSV, it's helpful in the sense that if somebody sneezes or coughs or breathes and they have the virus and you're in their direct vicinity, it can help prevent it from landing essentially in your nasal epithelium or your mouth. It's a little different from COVID, where you might breathe into a room, leave the room, and then I could come into an empty room and the droplets from COVID might still be in the air. Whereas this requires a little bit more of what we call direct contact. So the ways to prevent it essentially are extrapolated from the way it's transmitted. So washing your hands, not touching your face. If you're sneezing or coughing, cover it so that you're not spreading the virus out or potentially a virus out. This is where cleaning and disinfecting services becomes quite critical. And this is similar for RSV and the flu or influenza. And then do your best to avoid close contact with sick people and stay home when you're sick, which I think, like many over the last 2 to 3 years, just tried to take away some silver lining for what has been, I think kind of globally incredibly stressful event with a lot of terrible news. But I think maybe some silver lining is I think most places of employment now have a little bit more of a culture of doing this, which maybe was not the case in 2018 or 19. So hopefully if you're not feeling well, it's just better not to be in an environment where you can transmit that to other individuals. And similarly, for better or worse, I think many daycares and schools have kind of taken similar approaches to children. So in terms of how RSV affects adults, beyond just the usual 6 symptoms, it can flare underlying chronic illnesses, asthma, COPD, not listed on this slide, and then congestive heart failure. And it can cause a true pneumonia as well. More commonly, it will flare those with underlying heart or lung disease, though. And just again, to reiterate some of the statistics, this is prior to the season. We're talking about approximately 60 to 120,000 hospitalizations per year for those over 65, and 6,000 to 10,000 deaths for those over 65 per year. So it's multiplied over a number of years. And the risk factors are kind of similar, to those that we saw for the infants, which is rather than much younger age or less than 6 months, now we're talking about much older age or those over 65 having a heart or lung disease. So this is a risk factor in the sense that it can cause a flare of your underlying heart or lung disease, but you also are at risk just for more severe RSV. And then lastly, being immunocompromised. This generally refers to, there's kind of varying definitions of this, but generally those with an existing cancer, a blood cancer, those on chemotherapy. There are a few immunodeficiencies that can lead to this. So this is something, if you're kind of wondering, am I in this immunocompromised status, I would definitely discuss that with your doctor, because there are some particular definitions around what that means for this virus. And then in addition to the typical 6 symptoms, this can progress to pneumonia. And then, as we've touched upon, can worsen or flare underlying heart or lung disease. And this is just to reiterate, the ways of preventing it are really based around the way it's transmitted. So contact precaution. So again, for COVID, we're typically using droplet precautions. For RSV and influenza, it's contact precautions more so. There are cases and suggestions that all 3 of them can do all of them, but we're really talking about how the bulk of the virus is transmitted. And this is kind of a picture that a fomite is just referring to any kind of inanimate object, whether it's a doorknob in my example or a table in this example, that it just somebody touches and then has this virus on it, and then other people touch. So in phones, this is certainly a very important one as well. So I think fortunately there are a lot of at-home COVID tests, which has been great. And now there is a developed test called Pixel by LabCorp, which is a PCR test that can be mailed to you. It does seem, from a quick review, I don't have any personal experience with this either for myself or my patients, but it does seem like insurance would cover if certain criteria are met. And similar to the COVID test, you swab your nose and then the results take a few days. The caution, the caveat, or kind of disclaimer on these home tests, and this is true for COVID and this as well, is if they're positive, they're very helpful. I think if you have a home test and you're positive, whether it's for COVID, flu, or RSV, you can be pretty confident that that's the case. A negative test is not as meaningful. Due to it could be that the swab didn't quite get where it should be. It could be that the viral load was not as high as it is necessary. So I think if you're negative, you probably don't have it, but it's still possible you do. And actually, for my patients where they're very concerned about COVID, I'm typically having them do 2 or 3 home tests. It's not related to this test that's on the screen, but just a COVID test, because once you get up to that number, you're usually, and you're still negative, if you have symptoms, you're fairly confident that it's not COVID. But it is nice that this happens, particularly, or that this is available, excuse me, for this triple test, particularly given that sometimes it can be challenging to go to an urgent care, and certainly an emergency department for a test can be, many emergency departments across the nation are struggling with long waits. So that's a bit much for a test. And the other thing is, if you don't have it, you don't want to go and kind of put yourself in a environment where you might get exposed to it. So I think it's nice that these are available at home, but I do want to emphasize that these are for minimal symptoms. If you have a lot of symptoms, you should seek medical care. And then 2, that if a negative test is it's not 100%. I mean, there's quite a bit of margin for error there on the negative tests. And then in terms of hospitalizations, so what kind of drives them are respiratory symptoms, or cardiac symptoms, which can drive respiratory symptoms as well. And then pneumonia, whether that's bronchiolitis in infants or just a true pneumonia. And then the other one, which really applies to both age groups, is because of all these symptoms, it can be quite hard to maintain oral intake. And this is where the wet diaper comment that I was talking about earlier comes into play, is that some individuals just need to come in for intravenous fluids. They literally just cannot, whether it's babies or older adults, literally just cannot get in enough hydration orally. And this is, I think, it's frightening, particularly if it's frightening if it's an older adult, but it's particularly, I think, frightening if it's, your 8-month-old or 14-month-old. But dehydration, fortunately, it'll be frightening, but it's a easily reversible thing. Intravenous fluids, they get hydrated and should recover. And I do want to emphasize, with many of these things, it's just better to do it earlier, because as things progress, whether it's breathing, whether it's dehydration, the more advanced they are, there's generally more effort, and it's more challenging to reverse it as things get more progressed. So sometimes it's challenging because, in a practical sense, you're at home or wherever kind of wondering, oh, do we take our child, or you kind of know what it's going to entail. But hopefully you can get in touch with your doctor's office to get some guidance, and then if not, hopefully an urgent care or something is available to at least get a second set of eyes on him or her. So transmission of RSV, like we talked about, the infective person coughs or sneezes. And here, this is the virus, unlike them just kind of lingering in the air, it's the virus droplets, when they cough or sneeze, actually get into your eyes, nose, or mouth. And this is where masks do help, because they help on both directions. They help that it would prevent the infected individual from transmitting as much of the virus. And then they would help protect you from getting that virus to land in your nose or mouth. It would not help in your eyes unless you have, there are certain masks with face shields, or you're otherwise wearing a face shield. It can be passed directly by certainly, whether it's your grandchild or your own child, by kissing. And then, as we've talked about, touching a doorknob or any type of fomite, and then touching your own face. So this is really where I think some of, the habits that we all might have inculcated back in spring or summer 2020 actually can be quite helpful. Of kind of the sanitization, hand sanitizing, washing hands. It's really quite critical for the RSV and flu. And then prevention really just tracks back into the way it's transmitted. So if you're coughing, cover your mouth, or technically if you don't want to get it on your hand, because let's say you cough into your own hand and then it's still on your hand now. If you touch something, as you could just cough or sneeze into your elbow, inside your elbow, wash your hands frequently. Fortunately, hand sanitizer is effective for this. And then particularly if someone's sick, and even just otherwise, any type of contact might lead to transmission of this disease in cups, utensils, because it's essentially landing on that and then you're using it. And then in addition to washing your own hands after use, if there are high touch areas in the house or at work, if it's like a shared workstation, for example, those might be places where you just want to clean those high touch areas. A shared computer with a shared keyboard, keypads would be another thing. So any of those things, this is where those kind of wipe downs that had been being done historically will certainly be helpful. And the topic for today is RSV, and they will help prevent RSV, but this will also help prevent influenza. And then the other type of prevention is to stay home when we're sick, when we're talking about. And then, although, particularly in your house, for example, or in a larger work environment, you're not going to be able to wipe down every surface. So fortunately, ventilation does help. So this is particles. So this is, for example, if somebody with some form of infection comes in, and this is looking at respiratory droplets, and the kind of dots shown are how many droplets there are, particles there are. And if you have all your windows closed, etc., then there's really no particle reduction. They're essentially all still there. But if you then do that, and this is kind of just a nice schematic to show this, is if somebody's there for 4 hours and you have the windows open, you get a 93% reduction in the particles. If you keep that open and you continue to ventilate, that would be great. So a part of this is going to be a little bit more effective at preventing COVID than RSV. It will still have some effect, but it's just to emphasize, and this kind of underscores why we see the rates and the incidence of these viruses go up in the winter time, because you're just not as able to, it's not as desirable to ventilate your home when it's 10 degrees Fahrenheit, or, there was that cyclone, the snow bomb at the end of December. So that's not a time where you're going to be keeping your window open. So that's the challenge with this. So I think in the absence of this, if you're able to at least wipe some surfaces down that are high use, and then if there is a day where, depending on where you live, it breaks over 32 or it breaks over 40 or 50 or whatever your threshold is, even just doing it for some short period of time might be helpful, just to ventilate a little bit. And this is really a downloadable graphic, which might be nice to share with your own patients or anyone that has questions for you with just how to prevent this. Depending on who it is, you could go over each one, or just talk through the different mode of transmission. And I think once folks understand the mode of transmission, you're really able to kind of extrapolate from that mode of transmission how to avoid doing that. And then in terms of medical therapies for prevention, so there's really only one approved treatment for prevention of RSV. So it's called palivizumab. It's only approved for individuals that are infants that are born, premature, which counts as less than 24 months. They're premature and less than 24 months. I apologize. So if they're born premature and in the first 2 years of life, and if they have heart and lung disease. So essentially what the MAB, anything that ends with the MAB, is a monoclonal antibody. So it's essentially, and which actually has also received a lot of attention in the setting of COVID. So this is essentially an antibody against the RSV virus. And it's been shown in these individuals to prevent the rate of that they'll need hospitalization. So it's essentially in high-risk infants that this has been approved. So young, premature, or young and heart or lung disease. There's 3 other things that are in study, and there's kind of a summary of the kind of greatest or best potential scientific discoveries or findings of 2022, and 2 of these made the list. So one is nirsevimab. So this is under study for late preterm infants, and then actually term infants as well. So this is kind of to see if this is also to prevent. So I think we're pretty far away from this being widely administered, because one, you need to have proof of concept that it actually is effective. So there was an encouraging phase 2 trial. But the other thing in just the reality of this situation is that these monoclonal antibodies are fairly expensive to, one, kind of discover and create, and then two, once they're synthesized, they're fairly expensive to continue to manufacture. So the idea of having enough produced to give to every infant that's born, I think we're very far from that, because it needs to be mass produced ultimately. And it might not make sense just given the risk in term infants is not so high. This I think is probably a little bit more encouraging of a long-term possibility, which is that you basically give a protein to pregnant women, and antibodies they cross through the placenta. So the idea is that basically you give the pregnant woman the vaccination, she makes her antibodies, and then those antibodies transmit through the placenta into the fetus. And that fetus is then born with those antibodies. So that's they would last for a few weeks and months in the fetus or in the infant at that point after birth. And then lastly, there is an adult RSV vaccine that's been studied in those in 18 to 50. So all of the three therapies or preventative methods, I should say, on the right all have phase 2 trials completed that are fairly encouraging. So a phase 2 trial is it's not typically it's not typically placebo, it's not typically double blind, it's not typically a randomized control trial, although some can be. So the next step for these would be a larger phase 3 randomized control trial to see if some of these encouraging signals that we saw in the smaller and less sophisticated amount of data continue to bear true as it gets studied in a more rigorous way. That's for prevention. So treatment, once you have it. I kind of put this in the heading a little bit tongue in cheek, but that it kind of is generally the reality of it, which is, the same thing that your parents might tell you to do, your grandparents might tell you to do, drink some soup, get some sleep, take some Tylenol. That's honestly, for the overwhelming majority of people, that is the treatment. So you want to use anti-inflammatories, which acetaminophen, which would be appropriate. You do want to ensure that the fever does not get too high. Acetaminophen, again, would help with that, as with non-steroidals. And you want to ensure that individuals, children, adults are staying hydrated. And for infants in particular, you want to be sure you're monitoring their hydration status by the number of wet diapers. There are two available treatments. To my knowledge, they're not typically used in children, but ribavirin and intravenous immunoglobulin. So ribavirin is an antiviral medication. And then intravenous immunoglobulin, which also can be used in COVID, is just basically administering a non-specific antibody. So unlike those MAB medications we saw earlier, which are targeted monoclonal antibodies against RSV, intravenous immunoglobulin is just giving somebody immunoglobulin, just antibodies kind of more globally. And these are most helpful in those that are immunocompromised, because they just aren't able to mount the response that those with an intact immune system would be mounting. So they kind of help along with this. So these are really, and typically hospitalized immunocompromised patients. So these are individuals that are very sick and have some type of underlying immune deficiency. And that's why I just emphasize, for the overwhelming majority of people, it's just making sure you don't get a fever or have too bad of a fever, making sure you're getting rest and making sure you're staying hydrated. And then monitoring for progression of disease that might suggest you need to either take your child to urgent care, or maybe a parent or yourself, depending on the situation. And really, there's no role, because it is a viral infection, for antibiotics. There are a small number of people that will develop a pneumonia after this. They might need antibiotics. And then if it causes a flare of COPD, generally azithromycin or doxycycline would be a part of the care for a flare of COPD. So you might use it for that perspective. But if it's kind of pure RSV, an antibiotic will not offer any benefit. So beyond just kind of the general sickness that occurs in a child, runny nose, irritability, the emergency symptoms for infants where you want to take them to for urgent care is trouble breathing, fast breathing. So children do at baseline breathe much faster than adults. So if you're used to treating adults as I am, and you're concerned about a child, you'll have to look. And the respiratory rate actually changes by age as well. But certainly if it's your child or a child you're the care or someone is the caretaker for, you kind of be able to notice a difference. And the ribs pulling in with each breath, and this is similar to kind of neck or rib muscles going in for adults, just shows that they're working very hard to breathe, and that's not really sustainable. So as you start to see that, that's a sign that they also emergency care needs to be sought. Bluish or purple discoloration is a sign that there's low oxygen levels or cyanosis. Pale skin, chest pain, again, chest pain could be a sign of pneumonia. Pale skin could be a sign of either low oxygen or dehydration. If it's an infant that walks and they're no longer walking that's kind of a sign that they're having very bad muscle pain. Dehydration, irritable and withdrawn to the point where they're not interacting, that would be a sign to seek medical care. That could be because of the virus. It could also be because the virus and dehydration has affected their electrolytes. That there's a number of things that could mean. Seizures, and then temperatures above 104. And a part of this, and the reason of any fever in infants under 3 months is in that window, there's a risk for a lot of other infections. And unfortunately, it could be RSV and something else. So under 3 months, it's important to seek care. And then over that age, you're looking at that 104 cutoff. And then this last one, that someone's starting to improve and then they get worse, that essentially suggests what I was talking about earlier, which is that now there's this new bacterial infection. So RSV does not really have a waxing and waning course as some illnesses do. Once you start to improve from RSV, you should continue to improve from RSV. So basically the recurrence of whether it's a fever, cough, or whatever symptoms it might be suggests that they were improving or recovering from the RSV, and now something new has developed on top of that. As a kind of disclaimer, this is not a complete list. I think so. If there's something you're concerned about, and I would just encourage this globally, is getting able to update your child's pediatrician, or an urgent care. That these are the resources that are there and there to be used. And then if there's something on that prior list or the prior slide, they should seek care urgently, or you should seek care urgently. Emergency symptoms for adults, again, very similar. So trouble breathing, shortness of breath, and the adult, unlike the child, will be able to articulate, or an infant would be able to articulate it. But you're also looking for those withdrawal of rib muscles, those withdrawal of neck muscles, bluish or purple discoloration for the same reason as prior, which is low oxygen levels, seizures, weak or unsteady or severe muscle pain, not urinating, again, a sign of dehydration. And I should say, when I said adults can articulate this, but some of these are occurring, unfortunately, in older adults that may have other cognitive issues and might actually need to be monitored for them and unable themselves to articulate it. If they're typically not dizzy or confused, that would be a sign that RSV might be affecting electrolytes, and should be checked. And then consistent pain in the chest or abdomen. This could be a sign of pneumonia, or that the RSV is causing a flare of an underlying heart or lung condition. And then chronic medical conditions getting worse. I would say from a practical perspective, this is really the most common reason for admission from RSV. So if it's somebody you know has CHF, COPD, or asthma, that's definitely, there's a high likelihood that that disease is going to flare up because of the RSV. And then, as we discussed previously, if they're feeling better, on a trajectory of improvement, and then start to get worse again. Kind of similar disclaimer as prior. And then prevention, and this is really across all three of them. So for right now, for RSV, there is no vaccine. Pelizumab is available for those that are premature and or have congenital heart and lung issues as a preventative. And we've discussed the higher hospitalization rates in previous years. And I put in the heading here, contact and droplet precaution, because really we want to prevent all three of them. To be honest, they're all, even if you don't get hospitalized, they're all fairly miserable experiences, whether it's for you or your patients. So I think trying to prevent it is really preferable. The flu vaccine, in terms of prevention, it's transmitted via contact, so similar to RSV. everyone in healthcare, myself included, gets vaccinated against the flu. It's kind of a requirement in most hospitalizations or employers. The way that is done at a high level is that we look at the serotypes or strains that cause the most disease in South America or other seasonal variations, and kind of try to prevent against those three most common ones. So it's definitely not 100%, but it will, reduce the most likely strains you're exposed to. And then COVID, I think the vaccination there would be a whole nother topic or talk, but I think many are familiar with them. And there was a seasonal bump, again, fortunately not as bad as last year, but still a seasonal bump, and we seem to be coming a little bit back down for all of these, and hopefully that trend will continue. There's also a possible vaccine, RSV vaccine, in those that are older, and this is focused on this population, unlike that 18 to 50 years age group that I showed on the slide prior, because these individuals are at much higher risk. This is their ongoing phase 3 trials. The preliminary data seems to be fairly encouraging, but I've not seen the data or the kind of peer-reviewed publication made widely available yet. So I just put a little asterisk on this, but this is what we could see this upcoming year as a vaccination available for those that are older than 60 and therefore at higher risk. There are resources available both in the, as I talked about, in the acutely ill setting, and then just to understand these a little bit more from Allergy and Asthma Network. And this is just a nice kind of infographic on the virus that Allergy and Asthma Network has available, and it might be a nice printed handout for some of your patients, or to refer them to, which I do in my own clinic. So with that, I'll thank you all for your attention, and I would be glad to take any questions that might have arose during all of this.
Dr. Tejwani, thank you so much. I learned so much today. And one thing that really stood out to me is having that second set of eyes. And if there's a time when you think, I wonder if I should, and then if the next question is, should I go to the emergency room? Usually follow up on that. It sounds like it's what you're saying. So
yes. Yeah, and I'll exactly, Andrea, and thank you. And I'll just sharing a kind of personal anecdote, as we went through this with our 11-month-old in October. We had the same conversations. I talked about the respiratory rate. We tried to measure his respiratory rate, which, I'm laughing because an adult doctor measuring an infant respiratory rate is not as straightforward as you might imagine, but that's what we did. We ended up just, and I'll say it's better to go at 5 p.m. or 6 p.m. than at 2 a.m., and that's the other thing. And then you just kind of rest easy. So yes, I completely empathize with my patients. It's a bit of a pain at times, but unfortunately it's the right decision.
Okay. Yes, wonderful, wonderful information. So a couple of our questions here. We have what age or diagnosis for the recommendation for a Synagis vaccine?
For which vaccine, I'm sorry?
For the Synagis is what they have in here.
Oh, this is referring to the age over 61?
SYANAGIS. I know that there was one that they had for preemies at one time. Not really, and what I might be seeing here. Yeah, you know what I'm talking about.
Yeah, I see. Yeah, I'm sorry. So this is referring to the brand. I apologize. This is the brand name of the palivizumab. So I guess it's actually technically not a vaccination. It's a monoclonal antibody. So it won't confer long-standing protection. It would just be kind of a administered antibody. So my understanding is they're using 24, 28 weeks as the cutoff, but it seems to be varied. And I saw that the American Academy of Pediatrics did not change the cutoff, but they did recommend, if historically it's been 5 doses, but extending that course if it's been a longer course. So I think it's usually in the 24 to 28 week range. I suspect that, again, not practicing neonatal medicine, but that it's a very case by case decision. But I think that's kind of the general guidelines from what's been identified.
Okay. Thank you. And another question we have is, how long is the transmission for RSV?
So this is if you're sick. Yeah, as far as I've seen, it's really if you're symptomatic. And this is another kind of advantage we have combating RSV rather than COVID, where there are many asymptomatic carriers. It kind of lingers for a longer period of time. So RSV and the flu generally, if you're symptomatic, you're transmitting. And once you're no longer symptomatic, you're not coughing out those viral droplets. So we tend to be less symptomatic or less transmissible, excuse me.
Okay, wonderful. Thank you for answering that. Another question we have is how long does RSV typically last in an adult? And then this might go back, the second part of their question might go back to some of the things that you mentioned as far as the treatment for cough and sore throat.
Yeah.
Kind of what grandma used to do.
Yeah. No, so I think for how long it lasts in adults, in the absence of immunocompromised status, in the absence of heart or lung disease, it would be really less than a week for most folks. So most folks are kind of looking at 3 to 5 days. If there's any of those other things, it can vary and it can get much longer.
Thank you. Another question is, can you explain more about the test for RSV, COVID, and influenza? How would one get this? How much does this cost?
Yep. So I'll explain that with the disclaimer that I have no firsthand experience with it. But basically, it's called, I won't go back to the slide, but it's called Pixel. It's by LabCorp. And from what I saw, they say if you have insurance or certain insurances that cover it, they will express mail it to you overnight. And then you mail it back and you get the results within 3 to 5 days. So I think if you just search Pixel and the company that makes it is LabCorp, I know, I'm not endorsing it by any means, but it's just beyond availability, communicating its availability, that it seemed to be a fairly straightforward process. The only thing I would just emphasize is what I did in the talk, which is if it's positive, I think that's helpful. And you've kind of diagnose this a little more efficiently. But if you have worse symptoms, or if it's negative, if you have worse symptoms, you should seek emergency care. If you have worse symptoms, you should probably still think of yourself certainly as sick with some type of viral infection, which is why you tested yourself to begin with, and kind of isolate accordingly.
That makes sense. Okay, another question is, what are the lingering effects of RSV for adults? Someone said they have had it for 3 weeks.
3 weeks, yeah. Well, I'm sorry to hear that. That's a bit lengthy, which I'm sorry to hear. Fortunately, not much. So if there's underlying heart or lung disease, whether it's CHF, asthma, COPD, it can make those diseases linger. If somebody has a proclivity toward asthma, it can kind of basically cause asthma to manifest. And this is a welcome reprieve from COVID, where there's long COVID, there's all these types of kind of seemingly immune mediated symptoms that are occurring. RSV really does not have that unless you get very sick. If you get very sick and you're in an intensive care unit and you're hospitalized, there's consequences of that from just weakness and generally and deconditioning. But in the absence of underlying heart or lung disease, or it causing new heart or lung disease, it should not lead to anything very protracted. So 3 weeks is a little long, which I'm sorry to hear, and hope it starts to turn the corner soon. It should.
Thank you. Some people, myself included, seem to have bad luck when it comes to respiratory conditions. Another question we have is there any special concern for groups such as military, colleges, churches, and in-person meetings?
Yeah, that's a great question. I think, again, that's a part of why we're seeing what we're seeing this year. So I would say there's no, there's no like special consideration per se, other than that all those individuals, because of the way it's transmitted, will be at higher risk, and dorm rooms are going to be at a higher, dormitories are going to be at higher risk, in churches and other religious get-togethers where there's a congregation. Often parts of different religious celebrations involve, touching one particular thing as a part of the ceremony. So I think for all of those things, there's going to be increased risk, and certainly the same with military and barracks. So I think from a individual perspective, when you're in those spaces, or if you're counseling somebody in that space, you just kind of talk to them about the way it's transmitted and say, okay, so go through mass as you would normally. Just try not to, touch your face during mass the best you can, and then ensure you wash your hands right after. So that's kind of the just practical takeaway. There's nothing beyond that specifically for it, other than that they're a little higher risk of exposure.
Okay, thank you. And that's one of those things that people don't realize how often they touch their face.
Yeah.
and their eyes and their nose. And I used to do little trainings for kids in elementary schools, and I'd have this lotion that we'd put on, and it was glow in the dark. So we'd put that on and we'd give them a few minutes, and then we'd use this black light, and then you could see everywhere that they had touched, and their faces were covered and their noses. And I think it's just habit, and people don't realize how often that they touch their face, and then that's transmitting viruses. So
Yeah.
one of those things that's really hard to control.
Mhm.
Another question on here, and let's see, this one's actually about COVID. So
Mhm.
how soon after the bivalent COVID vaccine should an older adult plan on getting another booster?
I think at this point we're kind of, well, maybe not at this point, it's a understatement. So it's a little bit of building the plane as we're going, but most of these are immune-based measurements seem to suggest that the boosters have robust protection for about 6 months. And that's nothing specific to the bivalent vaccine, because we don't actually have that level of duration, or excuse me, that duration of evidence or data on the bivalent vaccine yet, since it's just been recently administered. But most of the prior boosters seem to suggest that they will last about six months with a good level of data. It's not like good level of protection. It's not like at month 7 you just drop off to where you were before you got the vaccine, but the booster. But there does seem to be a little drop down at that point. So I think if you're high risk or otherwise, in settings where it still could be contracted, and particularly if you haven't gotten it yet, because I think it's fairly apparent that infection does offer some degree of immunity. I think it is better with the vaccine unequivocally as well. But if you're high risk and haven't gotten it, haven't gotten the infection, I think 6 months would be reasonable.
Okay, thank you. And we have time for one last question, which is, do you think most people who had thought that they had a common cold in prior years really had RSV?
That's a good question. So I think it's possible. I wouldn't say most people. So generally, even before COVID, during the winter seasons when we had folks admitted or presenting to urgent cares or the hospital, they would get tested for RSV. Well, let me refer. The hospital, they would get tested for RSV. If you go to an urgent care, kind of like a walk-in, they usually just do a flu influenza test and not RSV. So if they were influenza negative, then definitely could have been RSV. More common in years prior would likely just be the rhinovirus, depending on the severity, which is kind of like a usual upper respiratory tract infection. There's the metapneumovirus, METAPNEUMO virus, and then coronavirus, like pre-COVID-19 coronavirus, which we've seen a few of. This is like the usual coronavirus that occurred as well. So I would say most people in years past have had one of these, but I don't know. I don't think it was mostly RSV. I think they just had one of these things. And the reason we don't go through that much trouble to test for them is because outside of influenza, where if you catch somebody in the first 48 hours, you can give them Tamiflu, there's really nothing special or specific you do, whether it's RSV or rhinovirus or the old, coronavirus classic, if you will, or metapneumovirus. It doesn't really, it's all that kind of supportive care, unless they're very sick. That's why we test in the hospital, because then it does change things.
Understand. Thank you for that. So thank you, Dr. Tejwani. If you can just forward one more slide,
Yep.
It will go forward.
Perfect.
Oh, one more. And one more. Sorry about that.
Oh.
So our next webinar it will be next Friday, January 17th, January 27th, if you'd like to register on our website. And I just wanted to repeat this. We mentioned this at the beginning, but I know we have people coming and going on the webinar. So you undoubtedly noticed that we have a different platform this year and had a few technical difficulties at the beginning. So thank you all for bearing with us. So previously you could download a certificate during the webinar. However, with this platform, what we're doing is you will receive an email after the webinar. You will have a lot of resources about RSV, and you will also have a link to be able to download your certificate. So thank you again for joining us, and we hope that you all have a great rest of your evening. Thank you.
Thank you all.